All right, so individualized treatment plan training, Buckeye Health Plan, October 15th, 2019. This is our disclaimer from the American Society of Addiction Medicine. I do have to mention that ASAM is not affiliated with Buckeye Health Plan and is not endorsing this training. We do use ASAM trademarks, but that does not constitute an endorsement of the training. You are able to download a copy of this training. Um, Now let's move on to the goals. Number one, my goal today is a lofty one, and it is to teach the importance and the mechanics of substance use disorder individualized treatment plans. And you will know that that is being accomplished, as evidenced by developing knowledge on how to construct an individualized treatment plan. I also want to introduce you to the Bloom taxonomy level. And as we look at the different levels of understanding, starting with remembering and understanding and applying and analyzing, we want to focus here on being able to use the knowledge gained from today's training in new ways. So the objective is to get you to the application level of new knowledge by describing the purpose of the problem statement, creating realistic goals that resolve the problems that have been identified on the problem statement, developing and assigning objectives or small baby steps to the patient to help them complete their overall treatment goal, and to apply interventions that are helpful in the patient in completing his or her objectives. So, in order to do that, it requires some rethinking, some redesign, if you will. And when you look at the ASAM criteria, and we'll look at the principles, we'll delineate the ASAM principles, it is fairly difficult to meet the ASAM criteria without some degree of program redesign. So if you're trying to implement this criteria into your existing program without some sort of redesign, it's like trying to fit a square peg into a round hole. Somewhat difficult, I might add. So, overview of today's session, we'll talk about resources where I went to research the treatment plan training. We want to go over some basics of a treatment plan. We're going to look at the Ohio behavioral redesign, of course, the ASAM 7 steps, and the ASAM justification on why we use treatment plans for continued stays. So the resources are, of course, the ASAM criteria book. There are numerous places where the language is used in the ASAM manual. For instance, patient-centered treatment is in the appendix on page 425 versus program-driven treatment or fixed length of stay is in the appendix, page 426. The use of individualized treatment plans is on page 6, page 13, and page 138 of the ASAM criteria manual. But when you look at how it should be constructed, I had to use some additional resources, including the Chemical Dependency Counseling, a practical guide by author Robert Perkinson. Also, the Addiction Treatment Planner by the same author, and ICANN notes for behavioral health treatment plans, and the Good Therapy blog. Those are the resources that I use to come up with the basics of a individualized treatment plan. So, training schedule for today, part 1, and we'll take a question and answer after each part. We want to look at the biopsychosocial assessment, problem statement, and stage of change statement. Part two, goals and target assignments. Part three is objectives and target dates. And part four is intervention and treatment plan reviews and how do we develop an individualized treatment plan. All right. So it's all connected. When we're talking about the body, we know that the body is made up of several parts. And if any part or system in the body is disconnected, the body does not work well. And so it requires some artificial support. And in the terms of the body, that might be dialysis, cardiac pacemaker, oxygen tank or wheelchair, whatever, some sort of ancillary support. Uh, and it's all connected in terms of individualized treatment plan as well. It has several parts, in which we'll go over in detail. You see the problem statement, goals, objectives, intervention, target dates, and discharge plan. If any part of the individualized treatment plan is disconnected, the substance use disorder treatment doesn't work so well. And it will require artificial support, and you may have to use a fixed interval treatment, or you have to prolong the treatment duration, or you may notice early dropout from treatment. So again, the red arrow is showing you where I would like to take you in terms of being able to acquire new knowledge and use it in different ways. Here is the basic structure of a treatment plan. This is the template that I use visually. It has numerous parts to it. First part is the problem statement. Number two, the primary goals. Number three, the objectives. Number four, the interventions. Number five are the dates, the starting dates, the target dates, and the completion dates. And these are only listed under the goals and the objectives. Number six is the treatment modalities. What type of treatment are you going to engage the patient in? And number seven is the discharge plan. So what I'd like to do now is to look at each one of these seven areas individually. The problem statement links the substance use addiction with the person's problems, their life problem areas. So we all know that they're entering treatment because of a substance use disorder. That's already understood, but how does that disorder affect this person's life? The primary treatment goal is to solve the problems that are delineated here on the problem statement. The objectives are specific action plans on what the patient will do. There are small measurable steps that will help the patient complete this overall goal, and they should include certain behaviors or data that can be counted. That is what we call measurable criteria. The interventions are specific actions that the counseling staff will take. And I want to just mention there's a lot of confusion here. In interventions, a lot of times I see treatment modalities here, a lot of times I see objectives over here, but interventions are what you, the professional counseling staff, will do to help the patient complete their objectives. And the overall purpose is to increase efficiency in the treatment process and to keep the patient focused. The treatment modalities are tailored to the individual's needs, but you notice I highlighted motivational enhancement for many of the patients that get stuck and you can't move them forward, or they're coming in the pre-contemplation or contemplation stage, or they are court ordered, mandated into treatment. You need to still use some forms of treatment modalities to get their buy-in or engagement. And the discharge plan needs to have some level of detail in terms of what's going to happen to the person once they leave this current level of care? Where are they? What is the targeted next level of care? What is the housing and transportation plan? Can they get to the next level of care? And do they have medical or mental health follow-up arrangements? So this is a very unique diagram because this is what we use to evaluate your treatment plan. So if you want to be totally transparent, which we do, we're going to go over what I look at when I look at your treatment plans. And my suggestion is no matter what form or format you submit these treatment plans, do your own assessment before you submit them. That would be a wise move. So on the problem statement that you will populate here, does it include patient-specific examples of the individual's problems? Or are you just listing a diagnosis? Well, there are several million people in America that has that same diagnosis. So how does that diagnosis affect your individual patient? On the primary treatment goal, does it include objective measures so that we can all tell when you hit the goal? So I see a lot of great goals, I see a lot of lofty goals, but it is rare that I see examples that you list for me to let me know, let you know, let the patient know when the goal has been met. And so look at your own treatment plan and says, does it include objective measures to determine when the goal is completed or will be completed? And are the treatment goal target dates reasonable? Uh, some are, some aren't. On the objectives, we look at, do they have measurable criteria? And I'm going to share a sheet with you a little bit down the road to delineate what I mean by measurable criteria. This is another confusing area. Um, and are the target dates compatible with the assignment? So if you assign the patient, say for example, patient will get a temporary sponsor while they're in residential 3.5 level of care. And so, well, we know that residential care 3.5, the patient receives services 7 days a week. And you want them to get a temporary sponsor, which is reasonable. Well, how long should that take? Should it take 1 week, 2 weeks, 3 weeks, 1 month, 2 months, 3 months, 4 months? So if you're saying it takes 3, 4 months for a person to get a temporary sponsor and they receive services 7 days a week, I would ask, is that reasonable? Is that compatible? On the intervention side, what are you doing? What is the professional counseling staff doing? The addiction treatment professionals, what are you doing to assist this patient in completing the objectives? Specific things. What are you giving them to read? What are you checking on? Are the interventions helpful? And lastly, the discharge plan. Did you include a discharge plan? And so all of the treatment plans should have a discharge plan. And discharge planning, by the way, is implemented on the initial treatment plan. So there should be very little reason on why there is no discharge plan. All right, moving forward. Ohio Behavioral Health Redesign started January 2018. And when it started, the providers were focused on the payment system. And I just want to share with you, as part of Centene Corporation, Buckeye Health Plan's parent company, part of Centene's mandate is that all of their medical directors maintain themselves in private practice. So I am affiliated with a substance use disorder treatment program that I helped found here in Columbus, Ohio. And so we went through every one of these problems in 2018. So going from one payment portal, MITS, to five payment portals with each of the MCOs, credentialing staff, contracting with five different MCOs, understanding the new CPT codes, making sure your electronic medical record was loading the correct CPT codes, and making sure the billing company was billing correctly. All those things in 2018 providers were focused on so that they could meet payroll, which is a very important function of any business organization. So, but the ASAM medical necessity criteria, I think the providers dropped the ball here. So much focus was paid on the billing system and the reimbursement. I don't think a lot of attention was given to the ASAM medical necessity criteria. So sometimes I think programs get stuck on the old paradigm, whereas you bill for the service without prior authorization, and there's minimum scrutiny, and you get the check. So that's a very smooth arrangement, but that's part of the old paradigm. The ASAM criteria guiding principles says, well, okay, now we want to move to a outcome driven treatment, which means let me see your treatment plan. Do you have a plan for this individual patient? And variable lengths of stay. Instead of everybody graduating at the same time, everybody finishing at the same time in this level of care, uh, individualized treatment should say everybody shouldn't need the exact same amount of time. Some people may need more, some people may need less. So let's see the variable length of stay. Are the treatment goals realistic for which level of care the patient is in? And interdisciplinary team approach. Uh, Definitely will require some program redesigns to implement this ASAM guiding principle and focus on the treatment outcomes. That is, well, when is the treatment goal going to be completed? And the medical necessity for treatment, and adolescents require special consideration. These are the ASAM guiding principles that should be reflected in your treatment of patients using the ASAM criteria. So in 2018 Behavioral Health Redesign, it brought the ASAM criteria along with this guiding principles. But provider or program redesign needs to embrace the criteria and the guiding principles. And this is a struggle that I see ongoing. From the managed care point of view, when I look at treatment plans, when I do treatment plan reviews, this is what I see. I see that it is business as usual. Very often, but not always, I am seeing some change as we move forward. I see fixed interval treatments continues, disguised with computer generated generic treatment plans. It's not really individualized. In fact, if I look at two or three treatment plans from the same program, oftentimes each patient will have the exact same problem, the exact same goals, the exact same objectives, and pretty much the same target dates. So there's been very little program redesign to sync with the Ohio Behavioral Health Redesign. If any of you all were present at the OMAS, the Ohio Mental Health and Addiction Services sponsored 3-day Train for Change implementation training, it mentioned that there has to be redesign to implement the ASAM criteria properly. You have to look at your staffing ratios. You may need to do some new hiring. You may need to move some people along that aren't capable of making the change. You may need to account for additional time that it takes for interdisciplinary team approach, so on and so forth. I want to spend some time next on the ASAM criteria 7 steps. If you follow these steps, it'll lead you to a good start on your individualized treatment plan. So starting up here, it ends down here at your individualized treatment plan. So the big paradigm shift between 2017 and 2018 going forward, we're really moving from fixed interval to individualized treatment program. One size fits all. Everybody gets 30 days here. Everybody gets 60 days here. Everybody gets 90 days here at this level of care, moving from that to a more individualized treatment. So step one is your biopsychosocial assessment. Nothing brand new here. That's been around for a decade or two. The second step is new, in which you take information from your biopsychosocial assessment and you populate 6 dimensions. Everything from withdrawal to medical to emotional behavioral, for relapse prevention to motivation, to housing. You populate these 6 dimensions with the information you got from the biopsychosocial assessment. And then step three, you look at each one of these 6 domains and you do a risk assessment and you score it. You do severity scorings that's rated from 0 to 4, with 0 meaning not much here at all, to 4 meaning this person is in imminent danger in this step right here. We need to intervene right now. So once you do your ASAM risk assessment and severity scoring, based on which of the 6 dimensions has the highest score, you will go to step 4 and identify those dimensions. Those are important dimensions. So if you have dimension scoring 3 and dimension scoring 4, obviously these are priority dimensions. These are your driving dimensions, because from those high scoring dimensions, you're going to take that information and figure out what is the optimal placement. What is the optimal level of care placement for this person? So you use the information in these dimensions. You use the ASAM crosswalk and dimension rules, and you get this person to the right recommended level of care. I think for the most part, Ohio providers are doing a good job here. If you follow the steps, or if you follow the yellow brick road, it'll get you to the right level of care. Going back to the driving dimensions, you see this is highlighted. Step 4 also takes you to step 6, because these driving dimensions, the areas that have the highest scores, are also the areas where are the priority problems. And these are the problems that you want to delineate, and these are the problems that you want to correct, treat, diminish when you get to the individualized treatment plan. When you get to the goal is to help resolve the problems that you identified in your driving dimensions. So it's all connected. There's 7 steps that goes from the biopsychosocial assessment all the way down to the problem list, which is part of your individualized treatment plan, a most important part, I might add. So clarifying the goals of treatment on page 6 of the ASAM criteria manual. Treatment tailored to the needs of the individual, guided by an individualized treatment plan that states goals that are realistic, measurable, achievable, short-term resolution of problems, or reduction of symptoms. So back to this basic structure. We'll talk about this a lot. This is my visualization. So my brain is a bit concrete when it's learning new things, and I do better when you show me a visualization of what you're talking about. And this is the template for the individualized treatment plan. Let's move on to the ASAM justification for continued stay. So just want to mention there's 2 types of criteria. There's criteria for admission, where you get the person to the right level of care. And then once they've been at the right level of care for X amount of days, X amount of weeks, and you need an extension of their care, there is a different criteria set. So justification for continued stay. ASAM criteria manual is somewhat ambiguous. If you look at page 300, this is what it says. To document and communicate the patient's readiness for discharge or transfer. No, nothing wrong with that statement. It says look at the 6 dimensions. So if the person is getting ready to discharge, if the patient is getting ready to go up a level of care, if the patient is getting ready to go down a level of care, yeah, you should look at the 6 dimensions at that point in change. But then it says if the 6 dimension criteria applies to the patient existing problems or new problems, the patient should continue in treatment at the present level of care. Now, when you look at that and you ask yourself, does this suggest that the 6 dimensions, which is admission criteria, is it used as a basis for continued stay? Here is the ambiguous nature of the ASAM criteria. So when we look further down on page 300, you can't stop there. You have to keep reading. It says the following. Continued service at the present level of care is based on patient progress or non-progress towards their goals as articulated in the individualized treatment plan. So obviously you must have an individualized treatment plan, and obviously you must have some goals on your individualized treatment plan to determine whether there's progress or non-progress. It says new problems that can be appropriately treated and can only be safely treated at this level of care. So if the patient is making progress, if the patient is not making progress, or there's new problems or exacerbation of old problems that can only be delivered safely at this level of care, those are the things you use to determine continued stay or continued service. So other pieces of evidence came from the OMA-sponsored trainings, Train for Change, the Skills Building Journal. It said the length of service should be based on the progress the patient is making. That's on page 10. It said achievement of goals on the treatment plans determine the length of stay. And you should summarize the treatment plan progress with the continued stay reviews. That's done with the insurance company. So looking at the level of care versus the length of stay, two separate criteria sets. The level of care placement, yeah, you should look at the ASAM 6-dimension assessment. You should look at the dimension rules. These are the two criteria sets that you use to determine the right level of care, whether that is going to be, well, should the patient go through detox, which is now called withdrawal management, or should they go to residential or partial hospital or intensive outpatient or outpatient? The level of care is, these are the criteria sets right here. But once you get them to the right level of care and they need additional days or additional weeks, now we're looking at progress on the treatment plan, not the ASAM dimension rules, which are admission criteria or criteria when you move them to a different level of care. So we will get right into part one, and then we will do a question and answer after part one. So part one, biopsychosocial assessment, problem statement, and stage of change statement. The objectives for clinicians is to be able to justify the problem statement with concrete examples. Clinicians will elicit patient response to determine the correct stage of change. The biopsychosocial covers 6 dimensions. It assesses strength and barriers. It identifies which dimension is the priority for this treatment at this particular level of care. Whereas the problem statement, I believe, is the most critical step on the whole individualized treatment plan because it is the start. So if you have errors on the start of your individualized treatment plan, chances are you're going to have errors along the way. So the problem statement should link the substance addiction. Now we know he's got opiate addiction, she's got alcohol addiction, she's got methamphetamine addiction. We know they've got this addiction, but what problems has it caused in this person's life? Give me some specifics so I can pick your patient out of 1,000 other patients with the same diagnoses. So examples. and when you list a problem statement, I suggest you list as evidenced by what? How do you know this is the person's problem? Well, loss of employment. He's lost 3 jobs in the last 2 years. Loss of child custody. His kids are in children services protection. The case got open this year. He's got some physical problems. Hepatitis C has not been evaluated, not been treated. He's lacking housing, as evidenced by him living in a homeless shelter for the past month. And his relationships are terminating. He's separated from his spouse, separated from family members. These are specific pieces of evidence that your patient manifests as a result of their addictive disease. Once you get the detailed problem list and you present it to the patient, you can elicit a response in terms of where they're at. Are they totally unaware? Pre-contemplation. Are they kind of aware but haven't really decided to do anything? Contemplation. They're well aware and they're ready to make some change. They're in the preparation stage, and they've committed or they're practicing. These are the action and maintenance phases. So the stage of change should have some concrete evidence recorded on the problem statement, and I think it's done purposefully so that you can present information to the patient. So, I'm aware that CARF says you have to have patient-centered, patient-individualized statements. So you need to be somewhat structured in how you present information to the patient. So you do this great biopsychosocial assessment, you do this great problem assessment, and you says based on our dimensions and our scoring, we see that this addiction has caused you the most problems in this area and this area, as evidenced by these pieces of information. Give us your input, your thoughts, and what is it that you want to work on. That's how you lead the patient to the right areas that they need to work on, and you elicit information from the patient's mouth on what he or she is willing to do. So their response will give you some indication of the stage of change. Are they in agreement, minimalization, denial, or shift and blame, so on and so forth. So concrete evidence. Remember, patients coming out of detox or coming off the street, they're not thinking right. Their thought processes are somewhat slow. They're in concrete operations stage and of their informational processing. So you have to be concrete with patients. So and I wonder what our providers are thinking when I look at some of the problem statements and the goal statements, and they're so lofty and wordy and abstract that I have a hard time deciphering what are you really saying here? What is your meaning here? So someone coming off the street have been using up until yesterday, or somebody coming out of detox and still, has some minor withdrawal symptoms. You present them with abstract, lofty, wordy information. I doubt they can do very much with it. So they don't handle abstract concepts well during this early stage of recovery. It might take weeks to months before they get there, but the treatment plan, it has to be done within the first few days. So, and you've got to engage this person at some level. So you have to present them with clear, concise, concrete steps to implement change. Question: what if you do a problem statement and there's no concrete evidence? It is just sort of abstract. What if? What if? Well, how do you sell the rest of the treatment plan to the patient? If you're saying to the patient, these are your objectives, we want you to do this, you should learn this, you should demonstrate that. How do you sell that to them and you don't have any concrete evidence on your problem statement? How do you assess his or her motivation for change? And why would the patient be willing or motivated to do this really hard work or recovery when you haven't done a great job in giving me some concrete evidence? You haven't connected the dots on how the disease has caused the problems. That's why I think the problem statement is the most critical step on the treatment planning process. All right, let's do question and answer. We've got a time here. If you would send me a chat message, I'm going to stop recording at this point and do your question and answer. Recording has restarted. We are now at part 2, goal statement and goal target date assignment. That is what we should work on part 2. So part 2, for the clinician's objectives, clinician will be able to link the goal with the problem. Oh, that's big. The clinicians will be able to list concrete objective measures or evidence to allow the patient, the clinician, and the managed care organization to see, well, when will the goal be met or has been met? How will we know when we hit the target goal? How will we know? So the purpose of the goal, remember, is to solve the problem created by the addiction. And you know what those problems are. All you have to do is flip over to the problem list. You should have some concrete pieces of evidence on how this disease has caused problems for this individual. And so now the goal is to solve some of the problems that has been created by the addiction. The problems listed on the problem statement should be addressed on the goal statement. That is the connection. But this requires thought from the addiction treatment professional. The human factor, I might add. So goal number 1, let's just look at an example. I see this a lot, right? The patient will establish a recovery lifestyle free of all mind-altering substances. I think that has been copied and passed around because that is a universal, which by itself is not bad, but it's not complete. So if you list this as the goal, as solving this individual's problems, show me some evidence, some things that the patient or the counselor or the MCO will see when the patient has established a recovery lifestyle. How will we know, as Whitney Houston would say in her song? How will I know? Well, example, he will or she will have started MAT for substance use. That is consistent with a recovery lifestyle. Yep. Will have negative drug screens. That is consistent with a recovery lifestyle. They will establish maybe a temporary sponsor while in treatment. That is consistent with the recovery lifestyle. They will explore sobriety and life satisfaction with sobriety. All of these things are consistent with recovery lifestyle. And so they're starting to look at some measurable criteria. I can look here and I can determine when they start MAT. I can determine when they have negative drug screens or how many weeks consecutively they have negative drug screens. I can determine when they've gotten a temporary sponsor, and I can determine when you've had a conversation with them to explore sobriety and life satisfaction. So, question: how do you get to the target date then? Okay, you've made some progress. You've gotten to the goals here. How do we get a target date? Where does the target date come from? Where does the treatment plan target date? What do you pick it out of the sky? What it should it be based on? Well, here are the answers. Where does it come from? Well, you have to look at the treatment plan. You have to come up with a treatment plan before you can pick the target date, not the other way around, unless you're in a fixed interval program. And we all know that the target dates for those are always the same. It's always 30 days, 90 days, or whatever, right? So, but here you look at what is the patient's goal, what are the objectives, how long is it going to take me for this patient to complete the objectives, and when they've completed all of that at the end, I should know, well, they will have completed the goal. So that's how you pick that date. You don't pick it out of the sky. It's based. It's not based on length of the fixed interval treatment program. It's based on the length of the longest objective. So if I have 5 objectives, and objective 1 is 1 week, objective 2 is 2 weeks, objective 3 is 3 weeks, objective 4 is 4 weeks, objective 5 is 5 weeks, then obviously I cannot have a treatment plan target date less than 5 weeks, because I would not have given the patient enough time to complete his or her objectives to allow them to complete their treatment goal. So I have to look at what the objective dates are first before I can pick out the treatment plan target date. So that's why I say you have to look at the treatment plan that you come up with, and then you select the date after you've come up with the treatment plan. So let's take a moment of question and answer here. Let's see if there are any questions here. It does not look like we have questions, and so we will proceed. Now, we will take a break in about the hour, so we have about 15 minutes, and then we'll take a break so that we can refresh ourselves. Let's move to part 2, shall we? I'm sorry, part 3. We are progressing along well. Part 3 is developing objectives with measurable criteria. And if you notice on the slide, measurable criteria is highlighted in magenta. It's its own color. It's the only word in any of my presentations ever that has its own color. It is that important, measurable criteria. So we're going to talk about objectives with measurable criteria, and we're going to talk about target date assignments for the objectives, what I call subdates. Now, this is not in an ASAM. This is not in the ICANN behavioral notes. This is not anywhere. This is Dr. Pelt, subdates. So, objectives, clinician will develop objectives that will help the patient complete his or her treatment goal. That's a good thing. And the clinician will list each objective with measurable criteria, a really, really big thing. And the clinician will assign realistic target dates, another really big thing. So the purpose of objectives, well, you got to give the patient some small measurable steps. So you've heard the proverbial saying, how do you eat an elephant? The answer is one bite at a time. How do you recover from opiate, alcohol, and methamphetamine addiction? One step at a time, and preferably in small, measurable steps. And those would be objectives. Objectives help you get to the big goal, and it gives the patient skills. And this is a big word. So if you're in treatment, we'll assume that you do not have the skills to solve your addiction problem on your own. So you come into treatment so we can give you the skills that you need to live a clean and sober and productive life. So that's the whole treatment uh, purpose. And it allows for the demonstration of. Now, I got to teach you the skills, and then I got to make sure you got it. So teaching you skills is one thing. Having you demonstrate the skills that I've taught you is a whole different thing. So the objectives, you want to teach the patient the skills, and then you want to allow for demonstration of new behaviors. So some of these skills are going to be new behaviors, um, such as refusal skills. If you're on the street and somebody comes up and offer you to buy this particular drug, what are you going to say? What are you going to do? New behaviors. Show me what you will do. New attitudes. Demonstrating new attitudes about drugs. So, example I use a lot of times is it was my birthday. So it just happened to be my birthday yesterday, and so I did not buy cocaine for my birthday. I bought chocolate cake and ice cream. All right. So a lot of times patients with active addictions, they're not thinking cake and ice cream. Their attitude is my birthday. And so you have to help change those attitudes for the patient. And how would you demonstrate that? So new insights uh, and newly acquired knowledge, having the patients demonstrate the new skills, new behaviors, attitudes, insights. That is what you're trying to do to help them reach that objective of getting rid of all mind altering substances, right? So that is how you connect those dots. The description for the objective is a specific plan of action of what the patient will do, not what the counseling staff will do. Here is what it's what you assign the patient to do, things you've assigned them to do. You want them to do learning and performing actions that will give them skills. So you're teaching them new problems. All right, so they're learning new. You're teaching them new skills to overcome their problems. So they're learning and performing new actions. And it's more than just assigning a patient to a program modality group. It is not patient will attend group 5 times a week, 4 hours each. That's a program modality. That sounds like this person may be in PHP, maybe 20 hours a week. So that's a modality. That is not the objective. So objectives should have measurable criteria. Here is that magenta colored word again. And measurable criteria are behaviors, data, if you will, that can be counted so that anybody looking at the treatment plan can tell if the patient has completed his or her objective. And I'd like to spend some time on this because this is this is what traps a lot of people is this measurable criteria. So in many places it says you should have some measurable criteria. You should have some measurable criteria for your goals. You should have some measurable criteria for your sub goals, which are objectives. And it starts out with what the patient will do. Patient will make a list, demonstrate, produce, identify, complete, keep a daily log, role play, verbalize, make contact with, sign up for. These are things that you feel that the patient should do in order to gain the skills to complete their treatment goals. You assign them to do these things. Then the next question, these are the treatment assignments. These are the objectives. The next thing is to count. Well, how much of it should they do? How will I be certain that the person has got it? So I want to make them a list of 3 things. I want them to demonstrate 2 episodes. I want them to produce 3 consecutive negative drug screens. I want them to identify 3 factors. I want them to complete chapters 1 through 3. So this is the count. So if you want to have measurable criteria, you have to have things that the patient will do, behaviors, learning, skills, and how much of it do you want to count before you can say they've got it. I think they've got it. And then lastly, how long? And that's going to be your target date for the objective. How long do you think, you as the addiction treatment professional, how long do you think it will take your patient, our member, your patient, our member, how long will it take them to complete this assignment that you've given them? And it involves a lot of factors, right? It involves their cognitive skill set, it involves their educational skill set, it involves their motivational level. It involves a lot of things, but you have to take those into consideration and assign a date. And this date right here might be 1 week of treatment, and this date might be 3 weeks of treatment. And put the specific date down because that is your estimate. What happens? What happens if the patient does not meet the date? Well, obviously, you need to make some adjustments in your treatment program, in your treatment plan, and you may extend the date. You may extend the date, but you have to document in your treatment plan why he or she is not completing this particular objective and why they need additional time to complete the objective. So, questions on the objectives you should ask. Well, what new skills, insights, or behaviors does a patient need to complete their treatment goal? Because those things will be the objectives. How can I help the patient adopt these new behaviors? Those things will be the interventions. And what is my role in helping? Well, first, you're going to assign them. You're the addiction treatment professional. The patient does not know how to assign himself or herself treatment objectives. So you have to assign them, and then you have to figure out what can I do to assist, and that takes you back over to the intervention side. So realistic target dates, when you look at the assigned task or objective, how many days or weeks does it really take to complete that task? Common sense. Now, common sense, when you submit your treatment plans, if you have every single objective with the exact same date, I would not expect that for individualized treatment plans. I would expect that for a fixed interval treatment plan. So you have to decide on which side of the road are you on. Are you still on the old paradigm and the fixed interval program? Or are you on the new paradigm where you're providing individualized treatment per ASAM? And so these are some of the things that I look at when we're looking at your treatment plans. So unrealistic target dates, I see a lot when the computer-generated treatment plans are used. And I would say they're good only for giving you some ideas of how to address the problem. They can't give you a realistic time frame for an individual to complete his or her objective because it depends on other factors: strength, barriers, motivation level, locus of control, stimulus control, prior treatment episodes, so on and so forth. So questions. When you're doing objectives, ask yourself, what is the realistic time frame for completion of the objective? And that's an individualized process, right? It takes some human input. The computer won't generate all of that for you. So now we're coming up on the 1 hour mark. I have this discussion, question and answer before moving to part 4. I will ask Brittany or Rob if you have any questions. Type them into the chat box. Hey, we are now entering part 4. We will look at interventions, treatment plan reviews, and we'll have an exercise on how to complete a sample treatment plan with the template that I provided to you. So, objectives: a clinician will assign a team member to help with each intervention, and we'll set up a treatment plan review schedule based on the level of care. And the clinician will develop an individualized treatment plan based on the problem statement. That is worthy of being highlighted, okay? All right, so interventions, when we look at objectives versus interventions, objectives are like homework assignments. And the interventions are like the tutor who helps you with the homework assignment and the parent who checks on the homework assignment to make sure it's done on time. So that is the role of the interventional list. The interventional list is supposed to help with the objective assignment and to facilitate to make sure it gets done on time. That is the role of the interventional list. So the statement, intervention should be selected by looking at what the patient needs to complete his or her objective, and it may include any member of your multidisciplinary treatment team. And the person, the description is the interventions are what you do, not what the patient does. Remember, what the patient does is the objective, what you assign the patient to do. So when I look at your treatment plan, the objective should say the patient will. But when I look at the intervention part, it's what the clinician will do, what the addiction treatment professional will do. And it can be anybody on your team. You just have to list who is responsible for this intervention. Because when it's done according to ASAM principles, which means an interdisciplinary team approach, if you have 5 objectives and 3 other people assigned to do some of these objectives, how will you know when their assigned intervention for that objective has been completed? How will you know? If they don't report back to you in some form or fashion, how will you know when their assigned objective has been completed? So interventions, the purpose, to increase efficiency in treatment. So somebody is bird dogging the patient, monitoring and making sure they're keeping it going, and to keep the patient focused on the treatment goal by completing the small baby steps called objectives. So imagine you're a middle schooler doing homework. How much homework would they get done if no one was checking and no one was monitoring? Probably not a lot. You need a bird dog, okay? The interventionist is a bird dog. Excuse my down south references. But the bird dog is a hunting partner, it's the pointer and the retriever. It does a lot of work, the interventionalist. Is a responsible team member that will monitor. Well, how are you doing on this objective I'm assigned? And will document progress. Okay, he's close to finishing this objective, or he hasn't done a single thing on this objective. I don't think he's motivated. And if they do complete the objective, how will you record that on the treatment plan so that the outsiders, that would be me at Buckeye Health Plan, so the outsiders looking in will say, okay, well, this patient has completed this objective on this date. So without the interventional list, handling their business, monitoring, documenting progress, documenting non-progress, and recording the completion date, how will the treatment plan ever get this data? How will I know? So you update the treatment plan on the treatment plan reviews, and I'm gonna give you a schedule of what ASAM says, uh, and not that Buckeye is mandating, but I'm just going to show you briefly what ASAM says in this manual. But when you update on the treatment plan reviews, you can do it in person. If your interdisciplinary team is sitting around a big table in a conference room, you know, looking at chart after chart, patient after patient, great. You can update it in person. Or if not, you may have to call in, or you may have to email, or you may have a Skype teleconference. So the problem is when the program has not been through a program redesign and there is no interdisciplinary team approach at any level, how is this information being updated? So if you're not updating your treatment plan for the reviews, then it's going to look like your patient isn't making any progress because no one is checking, no one is monitoring, no one is documenting progress or non-progress, and recording the completion dates. So treatment plan reviews should answer 3 questions when we have these calls. Is the patient making progress? Question number 1. Number 2, is the patient not making progress? And I should add, and what have you done about it, if anything? And number 3, are there any new problems or exacerbation of existing problems that are interfering with the patient making progress? And again, what have you done about it? Those are the questions that should be answered on the insurance review. And to be clear, I look at progress based on your treatment plan. I do not look at each individual progress note, group note, family note, art therapy note. I do not look at all those notes. That is not the role of the managed care organization to look at your notes. But there should be a summary of what's in your notes brought over to the treatment plan so we can update on how the person is progressing on the goal and how they're progressing on each individual baby step or sub-step called objectives. So treatment plan reviews evaluates the progress and outcomes of the treatment plan. It determines the patient response to treatment. The treatment plan reviews, what are the intervals? Well, according to ASAM, if you look here on page 110 of the ASAM criteria manual, also on the Training for Change journal, page 32, it says the treatment plan should be reviewed every 6 sessions if you're an outpatient. So outpatient, intensive outpatient, every 6 sessions. If they're in residential, it says that the plan should be reviewed every week or more frequently if the person is unstable. So that is ASAM language. Treatment plan review formats, the date, the time, the members present, problem summary, update on the problem, goal, objectives, intervention, updates, discussion of continued care, level of care, and discussion of discharge. So what I'd like you to do next, and we are trending down towards the end, I want you to read this attached biopsychosocial summary I'm going to show you. And then we're going to take that information from that biopsychosocial summary, and then we're going to develop an individualized treatment plan. So take a moment, give you 3 minutes to read this through, and pick out the areas that you would suspect would be important in developing the problem list for this patient. All right. So this is a summary of the biopsychosocial assessment. This is the summary. And so we're trying to do those ASAM steps. So we're looking at going from uh, step 5 to 6, I believe. We're going from the psychosocial assessment and we're going to the problem list. We're trying to get to 5 to 6. We're trying to go to the 4 to 6, I should say. We're going from the biopsychosocial summary and we're trying to develop us a problem list. This is what I picked out as the patient's problems. She started using pain pills. She started out on a daily basis. She progressed. Um, she went from pain pills to heroin. Then, when she couldn't get the heroin, she went into withdrawal. Then, once she got addicted to heroin, she's overdosed 7 times and she was in jail. All related to starting out using the pain pill. So, when we look at this template, and we start trying to populate this template, this is perhaps what it would look like. All right, here's the problem. Her problem is the pain pill addiction. Or we might want to say opiate addiction, right? Opioid addiction. She went from pain pills, so from occasional use to daily use. She went from the pain pills to heroin IV. She's overdosed 7 times in the last 5 months. And she went through withdrawal, and I didn't add down here, she went to jail. She went to jail. So this is evidence that how the addiction has affected this individual's life. So now let's put some goals together that will help us solve these problems. So the goal start out generic. They all do, lofty and generic. Improve the quality of life by obtaining abstinence from all mood-altering chemicals. Okay, that's the lofty generic part. But how will I know when I get there? Show me, as evidenced by what? Well, in treatment, we want this person to have 4 consecutive weeks of negative drug screens. When she can do that, we feel that her quality of life will improve. Well, also, we want her to get on medication assisted treatment to help and prevent any future overdoses and for the for the continual withdrawal symptoms she might be experiencing. Um, the prolonged withdrawal symptoms. And then we want to educate her on the triggers and relapse prevention so that she will have some cognitive and behavioral skills to help the next time she's out of rehab and confronted with drug using individuals. The objectives might be okay, well, uh, you got to get the patient started on MAT, and we want to do that the first week that she's in treatment. We don't want to wait to week 7. The next objective, we're going to do random drug screens weekly, and she will have 4 consecutive negative drug screens. And if you're going to do 4 negative weeks, you at least got to bring this out to week number 4, target date. The third objective, patient will identify 3 things that have led to continued drug use. We'll give her week 3 of treatment for that. The interventions, well, who's going to schedule the poor woman for MAT? Can she schedule it herself? No, we get the case manager to do that for her. So we want to schedule her and make sure she gets to the MAT treatment. Second intervention, Staff will discuss the results of the weekly drug screen and provide education on trigger avoidance. That's going to be the primary counselor. Third intervention, the staff will engage patient in weekly gender groups to identify triggers for drug. That's going to be the group counselor. So we're going to assign this intervention to the group counselor. So the group counselor is going to have to know my patient and says she's identified one thing, she's identified two things, she's identified three things that has led to her continued drug use. So that's how this works in general. So now when I look at treatment plan reviews, here are the deficits. I'm going to show you the deficits. You've probably already seen some of the language that I used on the deficits. The primary treatment goal does not have any objective measures. I can't tell when the goal has been met. There's no individual target dates for the objectives, okay? There's no treatment plan. Now, this is an old one. I don't see this much anymore. Or the treatment plan review is weeks or months ago. So if you're asking for, say today is the 15th, and you're asking for 2 more weeks of treatment, and I look at your treatment plan, the last review was in September 2nd, but you're asking for days from the 15th to the 30th, but your last treatment review was a month ago. Well, how can we determine how the patient is doing in treatment? You haven't even reviewed the treatment plan, so that when I look at it, I don't have any current information on how the patient is doing. Okay, another example, the primary target goal is no objective measures to determine when the goal has been completed. I do this one a lot because I look at the goals and it leaves me hanging. Or the objectives have no measurable criteria, or there are no interventions, or I can't tell whether the patient is progressing or non-progressing. In an IOP program, and yes, we have some products where we review IOP programs, so prior authorization may be coming for that down the road for you as well. The IOPS program is 6 days a week. There's no updated treatment plan or treatment plan review, so they're providing treatment, but they're not updating the treatment plan or the treatment plan review. The initial treatment plan has no objective measures to determine when the goal will be met. The target date of 8/15 is not associated with any actions or tasks that the patient was expected to do. There are no specific actions, which means interventions, by the clinical staff to help the patient complete the assigned objectives. Last few comments as we move to the end. No clinical information to determine progress or non-progress in treatment. Last covered day remains the same. There's no treatment plan. This I don't see very much anymore, thank goodness. So we are getting some kind of treatment plans. On the treatment plan, the primary treatment goal has no objective measures to determine when it will be completed. The objectives have no measurable criteria to determine when they will be completed. And there are no individual intervention. These are actual notes, denial letters that I sent out to patients and providers because I could not determine whether your patient was making progress or non-progress in treatment. All right, so this brings us to the end of our session. I will stop recording so that we can take this information and upload to the provider portal, and then I'll take a few moments for question and answer. Thank you so much for attending.